This is part two of the three-part medical emergencies lecture series. Today we're going to be covering endocrinology, hematology, and immunology, as well as talking about anaphylaxis and disorders of each of these body systems. So we're going to start off first with endocrinology. So the endocrine system is the way that the brain actually is able to communicate with the organs, the targeted organs, and it does it through this system. And the messengers that it sends are called hormones. And the hormones are secreted by glands. And the way that the brain actually maintains homeostasis is through secretion of these hormones by these glands to give cells specific direction. And it does it by creation of proteins inside the cells. When the hormones are activated, they attach onto the receptor sites on cells, they create a protein. So to put it simply, what are proteins? Proteins are the language of cells. So proteins are strands of amino acids. Amino acids are words, proteins are sentences. And the way that proteins are created in cells is by activation by the cell, by a receptor site located on the outside of the cell membrane. When a hormone is attached to this receptor site, it activates the creation of a protein by transcript RNA and messenger RNA, and this protein tells the cell to do a specific function. So this is the communication. So if you think about it, hormones are kind of like emails that the brain sends out to targeted organs and organ systems to do specific functions, all in an effort to maintain homeostasis. So there's different types of glands that we have. We have our exocrine, which are outside the body. These secrete chemicals for elimination, like ducts that carry secretion, like sweat glands, things like that. And then we have our endocrine glands that secretes chemicals for use inside the body. These are the messenger delivery systems. So these hormones, these emails that are released in the blood, travel through the bloodstream but are picked up by the targeted organs, the receptor sites that are on the targeted organs, targeted cells' membranes, creating that protein I mentioned that gives the signal, the command to the cell to do a specific function. And we have different glands that do different functions. Now these hormones can either bind to the receptor site, causing that protein to be created, that's known as an agonist, or they can be an antagonist. They can block the receptor site and prevent a function from occurring. How do hormones work? Primarily, they work through what's called a feedback mechanism. And this feedback mechanism is more driven by the environment than by the brain itself. So it's faster acting than would be if the brain has to trigger it by the process of it diagnosing that there's a problem. A feedback mechanism is in place to allow this function to occur. Hormones are regulated by the brain, the neural control of the brain, but other glands can actually control. Like the pituitary gland is known as the master gland because it regulates the activity of all the other glands. So endocrine regulation, in an effort to maintain homeostasis, uses this feedback mechanism to balance everything out. So to look at it, stress it causes a sympathetic nervous system response. The way that we do that is release adrenaline from the adrenal glands, that norepinephrine and the epinephrine. Okay, now once the stress stops, then the production of epinephrine drops off and the body's no longer in sympathetic tone. It now reverts back to the default parasympathetic tone setting. Disease states can cause a feedback mechanism to occur as well. A cell will send out a distress signal, and the distress signal it sends out is an amino acid known as a prostaglandin. And this prostaglandin is read by the body mechanism as a feedback mechanism, and what ends up happening is the body responds in turn to correct the problem. It's like a distress signal. So this prostaglandin comes out and it begins the process of inflammation. So the hypothalamus and the pituitary gland, it is the neural control center for the endocrine system. The hypothalamic pituitary system controls all of the other peripheral endocrine organs. So it was responsible to regulate the the glands from secreting other hormones. The hypothalamus is located at the base of the brain. It helps control body functions and emotions. So it links the endocrine and nervous systems. The pineal gland is located in the posterior of the brain's third ventricle. And some cultures consider the pineal gland to be the third eye. Pineal gland is responsible for secretion of melatonin, and melatonin allows you to have a good dream state. It's good for overall mental health. The pituitary gland, once again, the master gland, it controls other glands, and it secretes some major hormones like growth hormone. And the growth hormone regulates the ability for the body to grow. So it starts to dip off as you reach adulthood. Thyroid stimulating hormone, TSH, well, it's exactly does what it describes in the title. It stimulates the thyroid hormones to produce their, thyroid glands to produce their hormones. The adrenocorticotropic hormone and the luteinizing hormone, follicle stimulating hormone, these are all hormones that have the purpose of stimulating other glands to produce their hormones, and they have different functions from sympathetic tone to sexual impulses and tones. So all this is stimulated by the master gland, and you can see on the picture what this pituitary gland, both anterior and posterior, are able to accomplish, how they can control all the other glands. You can pause this for a moment and take a look at it. So the thyroid gland secretes a hormone called thyroxine, which stimulates energy production in cells and puts you into a hypermetabolic state. In addition, it's going to secrete calcitonin, which balances our calcium levels. The thymus gland is really responsible for, has a major role in T cell function, the killer Ts, the helper and suppressor T lymphocyte cells, which is part of our cell-mediated immune system. The parathyroid gland is a calcium regulator. It's going to secrete the parathyroid hormone when you sense the blood calcium levels are low. Adrenal glands, they secrete norepinephrine and epinephrine, the adrenal cortex and the medulla. And they are responsible for sympathetic tone, but the adrenal glands also kick out a hormone called cortisol, which is going to increase your metabolic rate and works well with sympathetic tone because we're going to have to use more energy for this fight or flight mechanism. It also secretes aldosterone, and aldosterone is the trigger of the renin-angiotensin system, production of angiotensin II, angiotensin I with the angiotensin converting enzyme making angiotensin II, which causes vasoconstriction. So it's part of dehydration regulation. The pancreas is a digestive gland. It's responsible for pancreatic enzymes which break down food that's digested, but also in the Isle of Langerhans, these glands secrete both glucagon and insulin, part of sugar regulation in the blood. When blood glucose levels fall, glucagon is secreted. When blood glucose levels rise, insulin is secreted. The gonads have sexual responsibilities. In men, it's testosterone, and it's responsible for creating the male sexual characteristics: hair growth, muscle development, so on. Women have a balance of estrogen and progesterone that play a delicate balance in their 28-day lunar menstrual cycle that occurs preparing the body for the fertilized egg to gestate and create life. So you can see all the different roles that the endocrine system plays. One of the very most common ones we deal with is sugar levels we see in the emergency medical setting. So when we're addressing anybody with any type of problem, we still have that overall universal algorithm of patient management. Address any hazards, follow standard precautions. You know, we want to identify and manage any life threats. So our airway, breathing, circulation, it's all, the primary assessment is the same no matter what patient we have. Okay, make that general impression. Positioning and skin color, moisture, temperature will tell you a lot. Make sure the patent airway is existing, deal with any abnormal breath sounds. Always in the primary assessment, give oxygen at high concentration, above 24 breaths a minute. Less than 8, you want to think about ventilating. Circulation, we want to check skin color, moisture, temperature, of course. Get a good blood pressure estimate. Get blood glucose level determination if they have an altered mental status. Make your transportation decision and put the transportation as part of your ALS assessment regimen. Doing good history is vital when you're dealing, especially with patients with endocrine diseases like diabetes mellitus. And some poorly managed diabetes can include that polyphagia, polyuria, and polydipsia, that increased eating, increased urination, and increased thirst. The goal for these patients is to determine the level of consciousness and assess why they're in a comatose state. We think hypoxia and we think hypoglycemia. Continually reassess every 5 minutes for an unstable patient, every 15 minutes for a stable patient. Nationally, scope of practice, you're going to initiate IV blood glucose, dextrose, if you've got a blood glucose level of less than 60. Between 80 and 100, you can 80 and 120, you can still give dextrose diagnostically. And why do we say that? Well, we can't just base our glucometer reading as gospel. If the patient is unresponsive, they have a history of diabetes, and the blood glucose levels are 90, you can give an AMPA D50, it's not going to be the worst thing in the world. It might actually have some physiologic changes. Remember our transportation regimen for comatose patients if they're intubated, so reduce the displacement of the tube. It's always good to put a C-collar on, especially if you're taking them down the stairs. So endocrine disorder that we're going to be discussing, these different disorders are caused by hypersecretion of a gland, the hormone, or the inability for the gland to secrete a sufficient supply of its hormone. So diabetes mellitus is the inability for the body to metabolize glucose appropriately. And that is because there's not substantive insulin creation, either as a product of an autoimmune disease like juvenile diabetes, where the immune system attacks the beta cells and destroys them. They don't recognize them as being indigenous. They in fact think that they are foreign invader pathogens, and they destroy them. Or later on in life, type 2 diabetes, which is more diet controlled, where the insulin is being produced, but the sugar intake is so much that there's not enough insulin to go around. So remember, we need to have the fuel for cellular metabolism. The creation of 32 molecules of ATP is done through aerobic metabolism. ATP, as you remember, is the battery pack of cells. It's where the cells gain their energy, adenosine triphosphate. It's sheared into adenosine triphosphate. From adenosine triphosphate, it's sheared into adenosine diphosphate, and the resulting energy that happens in that reaction is the fuel for cells. So they burn that adenosine triphosphate, or ATP, very quickly, and they need to grow more. So to recharge adenosine triphosphate, they need to undergo what's called the Krebs cycle. It occurs in the mitochondria, the power plant of the cell, and it involves two very basic components, oxygen and sugar. Basically, a substrate of sugar is pyruvic acid. That's the usable part. But we got to get sugar into the cell. The only way to get sugar, which is a big fat molecule, across the cell membrane is we need a chemical mediator, this hormone known as insulin. Insulin needs to be around to get sugar into the cell, changes the permeability of the cell membrane. Even though the cell needs it, it's still too big to get into the cell membrane. So using that oxygen and sugar, that's aerobic metabolism, and that creates 32 molecules of ATP, and you waste CO2. That's great. Now, if you have a situation where you can't get sugar in because you have a lack of insulin, well, there's another way that you can have metabolism. You can still create ATP, but you, instead of burning sugar, the body burns fat. So they take a fat cell and they take an oxygen molecule and they burn it in the mitochondria in that Krebs cycle, and they produce about 28 molecules of ATP, which is manageable. It's not optimal, it's manageable. And they don't kick off CO2 with this production. The waste product of this type of metabolism creates ketones. Ketones are acidic in nature, and the way you get rid of ketones is you have to filter it out in urine. If you're diabetic and you can't get any sugar into any cells because you lack the insulin, then all you're doing is burning fat. And you become metabolically acidotic, and a substate of metabolic acidosis is known as ketoacidosis. And since it's brought on by the diabetes, it's known as DKA. So what happens when you're burning fat? The body doesn't realize that it doesn't have the insulin, so it begins to have issues where you increase your hunger. You're in a starvation mode, so you want to eat more. That's not helping because you're breaking down into sugar that can't be used. So what ends up happening, your blood sugar goes up. Blood sugar goes up, you got to get rid of it. The viscosity of the blood changes. You're also ketoacidotic, and was regulated by the kidneys, the metabolic buffer system. We got to get rid of all that acid, that metabolic acid, so we increase urine, polyuria. And because we're urinating a lot, we're getting rid of excess fluid, we have to replace that, and that's where the polydipsia, or excessive thirst, comes from. But all this is happening, you're trying to combat the metabolic acidosis, you're eating more, and your blood sugar's going up, up, and then you become hyperglycemic, and that's when you go into a diabetic coma. So insulin is going to get that sugar across into the cells. Diabetes has an insulin issue. So you can see how this is where the insulin actually, the glucose represented by G is in the bloodstream. Insulin allows that glucose to go in. Without the insulin, look at all the G's hanging out in the capillaries. Not good. The problem with this also is thick glucose, big fat glucose molecules thicken the blood and produce diminished blood supply. It gets too thick to make it down to these very, very, very delicate, narrow capillaries. Put into perspective, you can see around the G is a red blood cell. These capillary beds are one red blood cell thick. All right, so red blood cells, in one drop of blood there are 50,000. In 1 cubic millimeter there are 5 million. So try and put that into balance when these vessels are only one red blood cell thin, just how thin they are, and how increased glucose can change the viscosity of the blood and cause problems with perfusion and organ failure. And this is what ends up happening. These are the life-altering complications. The increased sugar can actually gum up the nephrons. The glomerulus will become gummed up and not be able to filter out and receive any more fluid. And we have renal failure. The increased burning of fat releases lipids into the bloodstream, and the fat levels rise in the blood. So these patients are at risk for MIs and strokes. In addition, the eyes have very, very intricate capillary network. Sometimes it's so thin that one red blood cell has to actually squeeze up against the walls to make it through, like a confined space. So just little changes in the plasma concentration of glucose can gum that up and cause interruption of blood flow and blindness. But really what these diabetics have, they have the neural network begins to get diminished blood flow, and we have neuropathies, especially places of the visceral, the autonomic nervous system. And that's why patients are susceptible to that silent MI we talk about. So type 1 diabetes is juvenile onset. It affects children. Why? Because it's an autoimmune disease. The body is attacking itself, and that happens right at birth. These patients require daily insulin injections to replace what the body can no longer create on its own. There's new technology now with type 1 diabetes where they don't have to take injections. They have a surgical implant of an insulin pump that actually monitors blood sugar and injects insulin based on blood sugar levels. So it acts almost as an artificial pancreas. Type 2 diabetes, this is when blood glucose levels are elevated, and it happens much later in life, or it can be diet control where you take in too much sugar and you end up building up sugar. Your body can't get rid of all of it. But when you get older, your metabolic system starts to break down, the pancreas doesn't secrete as much insulin as it used to, or it stops secreting insulin, and you develop this type of diabetes. This is type 2. It's not an autoimmune disease. So, realize that type 1 is easily treated. Type 2 can have really serious effects. Okay, so people who are on type 1 manage their diabetes pretty well. Type 2 diabetics, it's insidious. It creeps up. They have no idea it's happening because they were normal functioning for a very long time. So signs and symptoms, you're going to have a patient who has frequent urination, thirst, blurry vision, and then in later stages, unresponsiveness. And they might be at first time, you never even realize that they had diabetes. So make sure that every comatose patient, every altered mental status patient gets that blood sugar estimate, glucometer. And with diabetes, with type 2 diabetes, they don't have to inject their own insulin. In some cases, they take medication that boosts insulin production. But a lot of this is also diet controlled, where they restrict their blood sugars. During pregnancy, one of the most common metabolic issues that a woman experiences is gestational diabetes. It's a form of glucose intolerance. The cardiovascular system changes. Your blood supply is increased by up to 50% in some cases, and sometimes you have glucose intolerance. So this will increase your risk of type 2 diabetes, and it's usually resolved right before birth, and it brings on like really big babies. But women who go through prenatal care, about the 10th week, 12th week, they will undergo what's called a glucose tolerance test. They ingest a large amount of thick glucose, and they get tested, and they want to see if it gets dissipated in 4 hours. So they want to make sure that the insulin is not resistant to the glucose, and that will test for gestational diabetes. But can have some problems during gestational periods with issues with blood viscosity. So we want to always check for pregnant patient, even if they're not diabetic, always check for blood glucose levels. So what is hypoglycemia? It's too much insulin or too little food or a combination of both. patients are going to start with an adrenergic response. Sympathetic tone will kick in, because something you may not realize is that epinephrine, while it has alpha and beta qualities for the cardiovascular system, there are also beta receptors on the liver, and when activated, they create a protein that tells the liver cells to convert their glycogen stores into glucose. So it works just like glucagon. So when you have somebody like this, that diabetic shock, that insulin shock they talk about, it's an adrenergic response in an effort to create sugar. This is known as glucogenesis. Now, levels that drop below 45 or less, these patients will become unconscious. Our management, of course, if they can tolerate anything by mouth, is to assist them with oral agent, which is it's better to get into the bloodstream, and it can be handled a lot better. Then, of course, if they're unconscious, nothing passes by mouth. We go with either dextrose 50% solution, or if you can't get an IV, you go with glucagon. For that same purpose as they're doing with the epi, the secretion of the norepinephrine to stimulate glycogen release into the blood. Now, hyperglycemia and diabetic ketoacidosis, now we have high levels of blood sugar. And we're going to have that polyphagia, polydipsia, polyuria. And this will occur when levels exceed 120. This is when it starts. You can see as blood levels rise, we're getting more and more acidotic. That's a problem. Metabolic acidosis is a chemical instability in the body that can lead to unconsciousness and death. So we want to assess these patients. Some will have a fruity odor in their breath, but it's not a gold standard. What you're going to look for is the glucometer readings excessive. The glucometer will say high, not because it wants to be friends with you, but it's above 500 milligrams of 500 deciliters per gram of sugar, which is extremely high. If you go past 800, now we're in hypoosmolar non-ketotic coma. This is past the point of ketoacidosis, and this is now the body is shifting fluid into the vasculature, and it can cause, in some instances, brain swelling. This is a very serious issue. We have to infuse not only normal saline, but sometimes the sugar gets all burned out in the urine. We might actually have to give dextrose to this patient. So you've got to watch and make sure you do a glucometer test on all of your patients who have change in mental status or are unconscious. Pancreatitis, inflammation of the pancreas. This is a true medical emergency because you don't want any of the pancreatic enzymes to make it into circulation. They can destroy tissue and damage organs. Patients will present with flank or epigastric pain. They'll be nauseous, vomiting may occur, but the problem is with pancreatic enzymes causing organ failure. So supportive care pre-hospitally is really the best. IV pain management can be considered. That's fine. Makes the patient more manageable. You know, you can go with something like a Valium or morphine to help relieve the pain as long as their hemodynamics are good. But these patients usually it's brought on by excessive drinking, alcoholism. So diet control and lifestyle management changes are best overall outcomes. Now, the adrenal gland. There's insufficiency and then there's overstimulation. Adrenal insufficiency causes an underproduction of cortisol and aldosterone. And what's going to happen is patients are going to get dehydrated, weak, they can't maintain their blood pressure. So people who have adrenal insufficiency, this is something that's chronic in nature. They're usually, they're told to drink excessively and watch their urine output. One of the major diseases of renal insufficiency is something known as Addison's disease. Patients like this, they are very fatigued, they're anorexic, they crave salt and things like that, and their pigment increases. You see on the left is a normal hand, and on the right is a patient with adrenal insufficiency, Addison's disease. So what are we going to do for these patients? You know, this can be a form of relative hypovolemia, and relative hypovolemia is best treated with fluid resuscitation, as opposed to absolute hypovolemia, which is like hemorrhage, where you have a problem with a breach of the container. This is not. The container is okay, but we're dehydrated, so aggressive fluid resuscitation is good. 500 cc's every 20 minutes can actually work. Cushing's is now excessive cortisol production. So what ends up happening with this, blood glucose levels are going to rise, and bones are actually going to get weaker, people with Cushing syndrome. They're fatigued, and they end up burning up excess sugar, so their blood sugar will drop, and their skin gets thin or darkens. So our management is, of course, always focused on the ABCs. You have a history of Cushing's. Just realize patients with Cushing syndrome, they need to have their blood glucose levels tested. Even if they're not diabetic, Cushing syndrome can burn all this sugar. Hyperthyroidism, the most common type of hyperthyroidism there is Graves' disease. And what ends up happening is you can see a visible mass, like they call it a goiter, occurs on the neck. This is excessive amount of thyroxines being secreted. Inversely, hypothyroidism is called myxedema, and this is where our metabolic state slows. So instead of a hyperactive state with the hair thinning and the goiter appearing from the gland swelling, we're going to have a more slower metabolic state that can actually lead to coma. And these patients were, before they became comatose, they were fatigued, they felt cold, their skin is extremely dry. So what are we going to do for these patients? Well, just like any other unconscious patient, we got to support them. So a lot of supportive care. Airway management, breathing assessment, hemodynamics, get your pulse oximetry, your end-tidal CO2s, draw a glucose determination. You know, do your universal approach, because you can't just say, oh, it's hypothyroidism. But if they're on a medication like Synthroid and they're unconscious and everything else is checking out okay, then it's possible that they're hypothyroid. They're not taking their Synthroid, they ran out, or it's expired. These are things you look at. These are the clinical clues that you find at the scene. But the problem with these patients is you want to avoid any sedatives or narcotics or anesthetics. Now, if they're already suppressed, you don't have, that doesn't really enter into your assessment schematic. Hopefully not. So the endocrine system is interesting, but the most important thing you got to realize is blood glucose levels can be affected. So you got to be very careful. And once again, your universal algorithm for patient assessment will encompass all of this: airway management, breathing, circulation, blood glucose determination. All these things should be part of your overall assessment scheme. Now let's talk about some blood disorders. This is a rare thing, but we still encounter it. There's hemolytic and hemostatic disorders. And we know what blood does. We know what plasma does. Blood, by definition, is a loose connective tissue. It has a vital role, and that is to deliver not only nutrients, but oxygen to the cells, so they can undergo aerobic metabolism and charge up their ATP battery pack and stay alive. In addition to the delivery of these respiratory and nutritional things, they also deal with excretion, CO2, and end products of metabolism like uric acid and other substances that need to be excreted through the kidneys. They also contain white blood cells, which are part of our immune system. So blood has a major function in everyday life, obviously. It's comprised of 92% water, and then we have formed elements in the blood, the 55% total blood volume. So the formed elements include the blood cells, red and white, as well as platelets, and any other proteins that are in there. So this, by definition, is known as loose connective tissue. Red blood cell production occurs in stem cells that you find in either the spleen or bone marrow, and it's triggered by a hormone called erythropoietin. Erythropoietin stimulates these increase in red blood cells. Now, it takes 5 days to grow a red blood cell, and the average lifespan is 4 months. One interesting thing about red blood cells is they don't have a mitochondria. The only cell in the body doesn't have a power plant, so there's no ATP production. And the reason why is they're oxygen mules. They carry oxygen. That way they have no reason to use the oxygen. Because imagine if red blood cells needed oxygen to make ATP, they would never be able to deliver it on time. They'd use it all up before it got down to the tissue. So they don't have a mitochondria. So they're basically just free floating in the plasma, and they live for about 4 months, and then they die. And then they get recycled, broken down by the liver and the spleen, and recycled into new red blood cells. White blood cells, on the other hand, are smart cells. They are large number of red blood cells, and they are the frontline defenders against foreign invaders. They're derived also from stem cells, and there's separate types. There's all different types. Your immune system is designed based on your natural immunity, what you're born with, and then what you've been exposed to. You know, the immune system runs drills constantly. It comes in contact with different pathogens all the time, and it builds its own database. So each database is specific to each person's life experiences. Platelets are formed elements. They are part of the process of clotting. They're used kind of as the spackle that closes a breach of the cardiovascular system and forms a seal until it can be completely repaired. So the blood-forming organs or red blood cell production, well, we've got the bone marrow, we've got the liver, and we've got the spleen. They're all responsible for creating these red blood cells. And remember, like I said earlier, one drop of blood contains 50,000 red blood cells. 1 cubic millimeter, 5 million red blood cells. There are trillions of blood cells in our body right now. Now the immune system, along with the rest of the cardiovascular system and blood, it's part of the inflammatory response, how it attacks foreign invaders. An autoimmune disease is when the immune system perceives a natural or indigenous cell or tissue to be a pathogen and destroys it. We find that very common autoimmune disease is type 1 diabetes. So we have that native immunity, what we have at birth, and then everything else that we've acquired over our lifespan is that acquired immunity. One big way to boost your acquired immune system is to get your flu shot, to get inoculated, because it's kind of like running a drill in the body. You get inoculated with a dead virus that's sent down into the bloodstream, the body reacts to it, destroys it, but it remembers its genetic code. So when it comes across that organism again, even though it's alive, it knows how to kill it, sends that into effect, and you have a healthy immune system as a result. This is known as an immunoglobulin. This is a specific reaction to a specific antigen. That's part of your humoral immune system. Then we have our cell-mediated immunity, which has macrophages and T cells, which destroy pathogens. They gobble up a lot of dead tissue as well as these pathogens. White blood cells are produced in the bone marrow, and baseline count should be between 5 and 10,000. High-end normal is 10,000. Reserves past that are sent. We have 12 to 14,000. That means we have a systemic infection. It's been found that red blood cells have different types, and it has to do with their immune system's reaction to it. They have general types of blood. You have type A, which has the A antigen, and it has the anti-B antibody. So type A blood, people with type A blood cannot receive type B. they can only receive type A or type O. O has no antibodies around it. It has no antigens and no antibodies. So that's why it's called the universal donor. People with AB blood can only receive, people with AB blood can receive both A, B, or AB. That's why people with AB blood are called the universal recipient. They can also get O blood, by the way. And then in the 1950s, tests with rhesus monkeys found that there is another antigen that's out there in addition to blood type, and they call it the Rh factor. And you either have it or you don't have it. So the Rh antigen, if you have it, then you're positive. So if you have type A blood and you have the Rh antigen, then you're A positive. If you don't have it, you're A negative. So the actual absolute universal donor is O negative. It has no antigens. It won't be attacked at all by the body. So we end up having this body system in place. The balance of the cardiovascular system in blood is called hemostasis. We want to maintain it. There's the breach of the cardiovascular system will result in a drop in hemostasis. So stopping bleeding through vasoconstriction and platelet plugging, direct pressure on the external source is vital to preserve this blood. Now, the process of clotting is a cascade mechanism. There's different factors that one factor begets another. It's kind of like the Bible. Adam begot this, and he begot that, begot this. Factors beget other factors. So the trigger of one factor will trigger another factor, and another factor, and another factor. So this is a cycle, and it's called a cascade. And we can be initiated through an intrinsic pathway for internal inflammation, or an extrinsic pathway if there's a breach in the system. So understanding how the body's own cardiovascular system, the blood itself, is not only the way to deliver oxygen and nutrients, but it also can protect itself from rupture, is vital. Now, our care should always be universal. Okay, size up the scene, make sure it's safe for everybody to enter, and we do a primary assessment. Now, one very common hemostatic disease is sickle cell, and that's the production of red blood cells that are not that perfectly round, almost looking like a Lifesaver, a Sucrete. You know, it's kind of crescent shaped. And the hemoglobin doesn't actually work like it should. So patients who have sickle cell disease exacerbations complain of severe pain. If you need to do cervical spinal mobilization, you can base it on the mechanism of injury and your considerations. So this is sickle cell crisis. So this is the leading inherited blood disorder in the world. It's a gene defect of hemoglobin A. And you can see how this normal red blood cell looks round, perfectly round. The sickle cell looks abnormal. And as a result, it ends up getting lodged in bifurcations of the vasculature. And you see that in some tissue and joints. And that's why pain is a response with this. It causes inflammation of those areas that are clogged up. So you have this patient, you want to do a general impression, make sure their level of consciousness is okay. Check for signs of inadequate breathing and circulation, manage any life threats. If they have acute blood loss, we want to correct it. Okay? Are they showing signs of hypoxemia? We want to address that with oxygen. So it's a universal approach for everything. Make our transport decision. Is this a sickle cell patient crisis? Or is it hemorrhagic issues that may lead to hemorrhagic shock? All these things have to be taken into consideration when you make your assessment. Some things that can help sickle cell crisis: oxygen causes dilation and moves those cells along. Also, they respond well to pain management, like morphine and synthetic morphine. Find out, is the pain isolator felt throughout? Has there been any skin changes and internal bleeding? Sickle cell crisis can become serious if it causes a breach of the vasculature, which can lead to internal bleeding. Have they had the crisis before? What did they do the last time it was resolved? Are they on any pain meds? Did they run out of them? Who's their doctor? Why are they calling us tonight? What's different about this attack more so than others? Don't get tunnel vision just because they have sickle cell that the reason they're in pain is because of sickle cell crisis. It could be other things going on. So talk to the patient. With these patients, they're going to be in a lot of pain. What you're going to have is normal or rapid breathing even. You can have a tachycardic response. Skin can become pale, part of that adrenergic pain response. In addition to oxygen and pain management, fluid is also sometimes indicated. It's very helpful. Increase your blood volume, moves those cells along. These patients are great candidates for nitrous oxide. If your system actually carries it as part of your protocol. Great thing about nitrous oxide is it's a gas mixture with oxygen, and it's patient regulated, meaning you fill the non-rebreather and you hand it to the patient and say, when you're in pain, take a breath. So being able to regulate and control their own pain can actually help have a better outcome overall. So really what we're talking about here is maintaining that standard approach. Your primary assessment is performed. Make sure that all other life threats have been managed, and then focus on this pain management with IVs, oxygen, and even nitrous oxide or IV analgesics. And let the patient rest. And they probably need to go to the hospital to alleviate further pain. Usually patients in extreme pain never give you a hard time about going to the hospital, so it's not really an issue. But you want to, definitely if you're sedating them, you have to take them. If anything, you have to go through medical control. So make sure that we're on the same page with transportation before you start that regimen of pain management. Now anemia, now we have it's not an altered red blood cell, it's just not enough red blood cells. There's usually a congenital or underlying disease aspect to this. Iron deficiency anemia is the most common type. It's caused by issues with the GI system losing blood or excessive menstrual bleeding. Patients who have type O negative blood are basically abused by blood banks and they like to donate blood constantly. They can develop anemia. What are signs and symptoms of anemia? Well, the body's worn down, they don't have any energy, and a lot of times they are tachypnic. They can't catch their breath. There's a VQ mismatch. So they're breathing in versus what's perfusing is not working because there's not enough red blood cells. So we're going to focus on that. Let's talk about the respiratory center. We want to monitor the airway and breathing. Since there's not a lot of red blood cells, we need to increase that percentage of oxygen that's in the alveoli. By process of diffusion, getting those oxygen molecules across into the bloodstream, we want to get more oxygen into the bloodstream because there's not enough hemoglobin out there to pick it up. So we want to increase and have a higher percentage of what remaining hemoglobin is there, seeding those oxygen molecules. That increases oxygen delivery. But really, this patient needs to head to the hospital, understand that there are cardiac abnormalities that can occur, so do a 12 lead. Patients anemic, they're complaining of air hunger and they're elderly, do a 12 lead. Make sure that this patient is not having any type of an MI that might be hiding anterior septal. So that's anemia of red blood cells. Now if we talk about issues with white blood cells, that's leukemia, and this is caused by cancer of the lymphoid system. And what happens is these white blood cells are either not being produced, or if they are being produced, they're not being produced enough to maintain the immune system. So these patients are going to have a history of cancer. There's different stages. They're going to understand their underlying medical issues. Initially, these patients will go to the hospital because they'll be fatigued, have headaches, and then unexplained bleeding. This is a major issue with patients with leukemia. Management should be supportive. Oxygen, IV fluids, all paperwork together. A lot of these patients are going to have advanced directives in terms of resuscitation, so make sure we're all on the same page before the transport occurs. Lymphoma is another type of cancerous tumor. There are two categories. We have the non-Hodgkin and the Hodgkin. Non-Hodgkin can pass from generation to generation. It's categorized by progression. There's the indolent, which is very benign, the aggressive and highly aggressive, which attacks other areas of the body. Then we have the Hodgkin lymphoma, which is a highly progressive enlargement of the lymph glands, and patients have it their whole lives, but it peaks to where it becomes lethal at the age of 35, up to the age of 35, and then in the 50s it can occur again. So management, once again, supportive care, all your documentation should be in place. A lot of these patients are going to have advanced directives. That doesn't mean that you can't give them oxygen or keep them comfortable, but things like intubation and CPR, we need to figure out exactly what they want to do. What is their written wishes, not what they verbally express, because once they go unconscious, it's implied consent. Now, if you have an overabundance of red blood cells, now you've got polycythemia. That can be a problem too, because this can lead to other issues, cancer level stuff. It can go into blood clotting. It can increase the thickening of the blood, which can cause a reduction of blood flow to organs, causing tissue necrosis and death. So this is an issue. Patients with polycythemia, they're going to start having shortness of breath. They could actually have an obstructive form of shock. They could have pulmonary embolus. So once again, patients with a history of polycythemia who've developed sudden shortness of breath, you really got to think that they got a pulmonary embolus. So rapid transport to the hospital is a priority. Most people can walk around with polycythemia without a problem, but when it involves the respiratory system, a sudden onset, that's a precursor, that's an underlying cause of pulmonary embolus. Now, shock has stages, and we have our compensatory phase, where the body is maintaining good blood pressure, but they started shunting blood away from body systems, and those body systems are starting to go into anaerobic metabolism, and we're in the golden hour, because after an hour, these body systems are going to start to die because they're denied oxygen, they're necrotic, and they die off. As the body systems start to die, we end up going into multiple system organ failure, and that's irreversible shock. One of the end stages of irreversible shock is this uncontrolled hemorrhage issue known as disseminating intravascular coagulation. This has about a 95% mortality rate. It's one of the causes of irreversible shock, and we find it in irreversible shock. It is an actual terrible way to die, and it's basically what it says is the body loses its ability to be permeable to blood, to red blood cells. So the cardiovascular system, remember, has the openings are in the capillaries. So the capillaries are semi-permeable. They allow nutrients and water and oxygen and CO2 and other gases to carry across, but they never let red blood cells across. In DIC, they become so acidotic, the metabolic acidosis overwhelms them, they lose the permeability, and red blood cells now can pass over. And that's where we have the bleeding from every orifice. Our management for this, there's other things going on. So it's probably going to be part of the shock arena, just recognizing that this is an end-stage disease of multi-system organ failure is enough. These patients should already be en route to the hospital. Hemophilia is not like DIC in the fact that the permeability is altered and allowing red blood cells across. The permeability is fine. The hemophilia, they just can't clot effectively. Now, there's two primary types of hemophilia. You have type A and type B. Now, we're not going to know one way or the other, but what we know about both is that clotting is an issue. So these patients, It doesn't matter if they have von Willebrand or the type, it doesn't matter. They need to be seen at the hospital if there's signs of external or internal bleeding. They may need high flow oxygen in this instance. When you're starting an IV, be cognizant of the fact that they have no way to stop bleeding. So if you need to do an IV, do one, but be very cautious. Multiple myeloma, this is where plasma cells in the bone marrow are suddenly created abnormally. Forms tumors in the bone, and we have anemia, loss of production of red blood cells, as well as white blood cells, which makes the body very susceptible for infection. Patients with multiple myeloma have the early onset all the way to the end stage. So once again, our treatment is going to be based on what the overall care plan is for this patient, which is mostly supportive care. You know, look, find out, is there a MOLST form in place? Do you have a DNR? If this is a patient who is managed by a hospice, what is their plan in terms of pain management? You know, if this patient is unresponsive and they're on pain management, deal with the hospice nurse. Do you want to give this patient Narcan, have them wake? So your care has to be supportive in nature. Patients with transfusion reactions, they're getting the wrong type of blood. It's going to cause a systemic humoral response, very similar to an anaphylaxis. It's very dangerous. It's almost incurable. Complications, if they have that severe allergic reaction, the closure of the airway, circulatory overload, bacterial infection can result. So what's going to happen? Well, the best course of action is to stop the transfusion. And these patients, you want to maximize kidney perfusion, they need high levels of fluid resuscitation, similar to a burn patient. It's probably the best way you can manage this patient on the way to the hospital. Now let's talk about infectious diseases. Now, an infectious disease is a communicable disease, meaning it's able to be transferred from one person to another. The government has in place public health agencies that make sure that regulation of the way that we handle patients with communicable diseases is monitored. And OSHA is there to protect employees. The CDC protects not only the healthcare providers' employees, but the public at large. The Ryan White Care Act created a process to where notification could be given with respect to the patient's privacy as well as the responders' privacy. And that's where we have infection control officers who are notified by healthcare facilities, and then the infection control officer notifies the employee. So we keep a chain of custody and privacy. It's our responsibility to protect patients from healthcare associated infections. These are called nosocomial infections. And the best way to do it is to clean your equipment. Start every shift cleaning your ambulance. Wipe it down. Ask yourself this question: when was the last time I cleaned my blood pressure cuff? Here's a better question: when was the last time I cleaned the inside of my pulse oximeter? When you don't clean your equipment, you transfer your patient's infection from on the stretcher to the other patient that you come in contact with. So you can create a public health disaster by basically not cleaning after each patient encounter. And when we talk about cleaning, we're talking about 10% bleach solution, but we follow hospital guidelines. Now, as a hospital administrator, I've dealt with the Joint Commission for Accreditation of Hospitals. And what the Joint Commission does, they audit hospitals to make sure that they follow certain regulations. And one big regulation they look at is sanitary conditions. Cleaning a countertop or a stretcher mattress or equipment. 10% bleach, and we do it through a process known as wet time. Wet time is the amount of time it takes to dry in the air, not wiping it down dry. To be effective in maintaining aseptic technique and killing as much bacteria and virus as possible, you gotta have a wet time of at least 2 minutes. So you wipe down your equipment and let it air dry and make sure it takes at least 2 minutes to have happen. So that's really what we're looking at. Sheets are one patient only, and every time a patient is discharged from your ambulance into the ER, you run the same discharge plan as a hospital would when a patient is discharged from a bed. It's the same way you would expect when you checked into a hotel, to have it look exactly like no one else has been there before. You want to create that same type of setting for your next patient. This is your responsibility. In New York City, they give you 25 minutes to actually have that turnaround time. If you encompass 10 minutes cleaning your ambulance while your partner's doing the paperwork, I think we can all have a clean ambulance for every shift. We want to reduce communicable disease transference. As public health providers, that is our task, our mission. It's vital for our industry. Understanding the different conditions that diseases can be transferred over. It depends on the amount of the disease, the virulence, the ability for communication, like smallpox. The mode of entry, is it inhaled? Was it bloodborne? And the health status of the person who received it. They have a good immune system, they'll probably knock it out or not feel any of the effects. There's different mechanisms. Person to person is known as direct. Indirect is patient to stretcher and then stretcher to patient. There's droplet, airborne, and then vectored transmission. Hand hygiene is the primary protective measure. And soap and water, not just that alcohol-based Skell gel that we're so used to. That ends up drying your skin, that can get in the way of your normal immune processes. So it's good if you don't have the ability to wash your hands, but if you're dropping a patient off at the ER, one thing I know that they have an abundance of is sinks and soap. So wash your hands after every single patient encounter. If you have cuts on your hands, you got to make sure that you bandage them before you do patient care. And I would double up with gloves for every hand that has an open wound. In addition to gloves, make sure you have eyewear if you're going to have intimate respiratory contact, which means you're going to intubate. That's about as intimate as you can get. Intubating a patient who is conscious, that could be a pathway. If they cough and it gets in your eyes, you have a high probability of direct transmission. We have surgical masks, N95s. Something that's great to give a patient who's coughing is oxygen masks. A non-rebreather serves as a good barrier device, and it also provides negative pressure. That oxygen coming up into the bag is negative pressure. So as they cough, that oxygen is going to slow down any droplets from transmitting across the room. The Needle Stick Safety and Prevention Act requires all ambulances to be equipped with sharps containers. It used to be that only ALS ambulances had sharp containers. Now all ambulances have to have sharps containers. And it also encourages the use of needleless systems. So infection control is part of your standard precaution. It's the scene size up. It's body substance isolation. But in addition to having the external barriers, internal barriers are vital as well. Flu shots should be gotten every year to combat against whatever virus, influenza virus is forecasted to be in your area. In addition, make sure that you have hepatitis B vaccine performed. Draw titers every 5 years to see if the antibodies are still there. That reduces your risk of conversion. EMS departments have to have that exposure plan. It needs to be available for all employees to review. So when you're doing a patient assessment, maintaining that universal approach assures you that you're going to have a proper barrier system in place to protect you. The risk of infection is factored by what organism, the dose of the organism, how strong, virulent the organism is, which entry came in, and the resistance of the host, meaning did they have inoculation against it. So when we're managing these patients with potentially communicable diseases, we want to focus on the ABCs. We want to be empathetic. By empathy, I mean use that non-rebreather instead of a N95 mask, because the patient is going to actually feel better with the oxygen, and it's going to help their privacy, and you're going to show true empathy. And at the same time, balance it out with good patient care and good communicable disease prevention. One thing with communicable diseases, patients who have them are very prone to dehydration. Part of getting out toxins, the body will secrete it as diarrhea. They'll add excess water, so we can have a high probability of dehydration. Plus, they have periods of anorexia, they don't feel like eating or drinking. So IVs with fluids can actually perk someone up. So our general management principles, standard precautions, always standard precautions. Always dispose of your sharps. Even if you're in the back of the BLS truck, always keep a count where your sharps are. Follow your agency's exposure control plan and never be afraid to document any potential exposure. Now let's talk about some specific communicable diseases. Well, very common we have is meningitis. It's inflammation of the meninges. Bacterial is a communicable form and viral is non-communicable. How do you know who's got bacterial or viral? Blood work. So you're not going to find out pre-hospitally. If you're doing a transfer, you'll have a better understanding and know your exposure control. But either way, treat all potential meningitis patients as communicable. And come in contact with them, always do an exposure control report. So what happens? Well, it's swelling of the meninges. Transmission can occur by droplet through nasopharyngeal secretions. But usually it happens with prolonged contact time, exposure time. The time spent in the back of an ambulance, very, very, very slight chance of transmitting. So signs and symptoms of meningitis, it's fever, headache, stiff neck, and you have different signs. You have the Kerning sign, the Brzezinski sign. What really we're looking for is that rash in the lower back, down in the sacrum and the coccyx, that with a fever can tell you that you might be dealing with meningitis. So once again, put an oxygen mask on the patient, use your standard precautions, and post-exposure treatment includes a broad-spectrum antibiotic like ciprofloxacin or rifampin. Now, tuberculosis, Tuberculosis is a droplet transmission. It's not highly communicable. There's a respiratory center or skin infection. People at risk are usually malnourished or in close quarters, incarcerated people. There's new types of TB that's out there. That's the multi-drug resistant TB. It's called MDR TB. And then we have our extensively drug-resistant TB, the XDR. These patients who have this are usually isolated and sometimes incarcerated in a hospital. This is one of the few patients who receive a court order to stay in the hospital to finish their treatment regimen because it can take up to a year for this drug treatment known as INH therapy to resolve their tuberculosis. It is transmitted in airborne particles. Its incubation period is between 4 and 12 weeks. So you don't know when you've got it. Sometimes be in contact with a patient and 4 months later you've gotten it. You start showing signs. It's communicable when there are lesions that have developed in the lungs. And we get our detection through that TB time test, that skin test. So what are we going to be looking for when we assess our patients? Well, are they fatigued, night sweats? Are they coughing up blood? Coughing up blood is a real sign. It's a sign of either tuberculosis or cancer, lung cancer. So patients who are coughing up blood need to be evaluated at the hospital. We're going to put an oxygen mask on or a surgical mask. Your decision. I personally like oxygen masks because of the negative pressure. And also, if you're coughing up blood, you're probably going to need oxygen. And you report the tuberculosis exposure to the hospital staff, obviously, and your infection control officer. Pneumonia is inflammation of the lungs. Most are not communicable in nature. And people who are susceptible are those who can't really cough up the phlegm that's produced by the bronchioles, the secretions. So older patients, as well as smokers, who have a productive cough constantly, immunosuppressed patients, and children, especially younger children who may aspirate, don't have that coughing mechanism in place. Signs and symptoms will be high fever, chest pain, orthopnea, inability to lay flat without having shortness of breath. Most pneumonias are treated with broad-spectrum antibiotics, and they're very successful. Once again, they're having shortness of breath issues, so always good to put on an oxygen mask. Bronchitis is an inflammation of the inner walls of the bronchioles, and this can have an issue with flow of air into the alveoli, can lead to issues that resemble asthma. Laryngitis, we're up now at the larynx, at the start of the lower airway, so we're going to have a sore throat. It's usually viral in case of like croup, but we can also be bacterial in case of epiglottitis. Epiglottitis is going to actually occlude the opening, the glottic opening, because the epiglottis is inflamed. The drooling occurs in the epiglottis because it's in the hypopharynx, and the body thinks that it's trying to swallow something, so it'll start to secrete saliva. Issue with this is that this is a bacterial infection, and it's a droplet transmission, so the bacteria is in the saliva that's being drooled out. So once again, limit your exposure, always wear gloves, and then most importantly, clean your equipment when you're done. Common cold is it's virus in nature. It usually lasts a week. It's spread communicably by droplets, coughing, and sharing utensils. You see it happen in schools. One person comes in, and then families, children will pass it on to the parents, and so on. Mononucleosis is brought up by the Epstein-Barr virus. They call it the kissing disease because it's direct contact with saliva. But in addition to kissing, of course, with children it happens a lot because they like to share drinks and things, anything where there's saliva that possibly could be shared. Communicable period is very prolonged. It can last months. Mononucleosis management, make sure that you always wear your gloves when you handle these patients, and you have good hand washing techniques, and make sure you clean your equipment when you're done. Now, seasonal flu, once again, most seasonal flus are droplet transmitted. They are contagious, and they're communicable from maybe a day before the symptoms start to 5 days after onset. Now, here's the issue with influenza. A day before symptoms start, which means this is how it spreads. When they say when you have the flu, you just stay home by yourself and limit your exposure to other people because you don't want to give it to them. But that day before, you don't know you have the flu and you're out working, you're at school, you know, and this is how you actually can spread the virus. So there are ways to manage the seasonal flu. First things first, you got to protect yourself. I can't stress this enough as one healthcare provider to another. You have to get your flu shot, your annual flu shot. There is no valid reason not to get a flu shot unless you have a congenital defect that prevents you from being able to take that flu shot due to hypersensitivity. There is no reason, anything that you've heard in the news media, books published, it's all quackery. You should have your flu shot every year because not only will it reduce your risk of getting the flu, but you can get the flu and not even realize you have the flu because your immune system is so strong. So what happens then is that you're a carrier now. So you go to work and everything's fine. You got the flu from a patient a couple days ago. You have no idea. The virus is active in your body because the body's kind of like ignoring it, doesn't recognize it. You have very mild symptoms of immunoresponse, the inflammation. So maybe you're a little achy is a big deal. But now you're going from patient to patient and you're spreading that virus. And who are you coming in contact with? Sick people, immunocompromised people. So part of the process of the CDC to combat seasonal influenza is to do something called herd vaccination, where they go into a senior citizen center and just get a herd of people and just vaccinate all of them. Hospitals, schools, police departments, fire departments, all those people who come in contact with the public, that herd of people need to be vaccinated to prevent the spread. So that is your duty as a paramedic, is to not only get the flu shot yourself, but to preach to others to get the flu shot. Okay, now I'm off my podium. Now let's talk about some sexually transmitted diseases, shall we? Okay, so gonorrhea, what is it? It's an infection caused by Neisseria gonorrhoeae, and it's a sexual contact, so you will definitely not get it by working your job. Still, you got to prevent any issues, so you always practice good BSI. Syphilis, another sexually transmitted disease. This is caused by the Treponema pallidum virus. It's transmitted, once again, direct contact with fluids. So cleaning your stretcher and equipment after each patient contact will reduce this communication to other people. Chlamydia, transmission through direct sexual contact. The incubation period can take over 2 weeks to occur where you'll feel signs and symptoms. And it's an unknown in science if it's communicable or not, how it actually works. Chlamydia is easily treated with antibiotics now. Scabies, you're going to find patients, now we're moving out of the sexual thing, and now we're talking about skin irritants. Scabies is communicable through mites and their eggs that exist on skin. So if you have skin-to-skin contact, you can get scabies. Signs and symptoms of scabies include rash, intense itching, sores. It's an inflammation of the skin. So the best way to manage this is to always come in contact with patients. Unfortunately, a lot of homeless population, their poor hygiene can lead to scabies. They will have these bugs on them. They look for hosts, so they are happy on the skin, but they can jump from skin to skin. So make sure that when you have a patient with scabies, they have that reddish skin that's itchy, get them to the hospital, notify the hospital. They probably get showered, they get scabies that destroys it, but also make sure you wash your hands with soap and water, and you clean your equipment with 10% bleach solution and let it air dry for 2 minutes. Another type of treatment we have is Lindane. That's a good topical treatment for scabies. Lice, once again, another louse that comes from poor hygiene. There's head, body, and pubic louse, and this is direct contact. It can be skin to skin for body louse. So always wear gloves when treating these patients, and always wash your hands. Even if you're wearing short sleeve shirts, you want to make sure you go up to the elbows, any place where you have exposed skin. And there's different creams that can be prescribed to destroy this lice. Some bloodborne pathogen diseases we have, viral hepatitis. It's an inflammation of the liver, and there's different types from A to E. Same signs and symptoms, but different ways of transmission. So hepatitis B is the most serious, and it is a bloodborne pathogen that's needles, the primary cause. Sharing a needle, so needle to needle, skin, needle on skin, and then needle on skin. Incubation period is 45 to 200 days, so you might not even realize this for almost a year. But what happens is you have hepatic failure through the virus, and the liver can no longer do its cleansing functions. And one thing that the liver cleanses is ammonia and uric acid, and the buildup of uric acid will create this yellowish jaundice skin color, as well as the sclera in the eyes. So in addition to blood-to-blood contact, you can develop hepatitis C through sexual contact. Blood transfusions and organ donation, and moms can pass along to infants, even in utero. So how are we going to treat these patients? We want to manage them using gloves. And if you are ever exposed to somebody's blood and it gets into your blood, realize that you have to notify people right away. Don't ever be embarrassed to talk about exposure, because you can be given a cocktail that has a 75% efficacy of conversion, so you will not get hepatitis C. In order to have hepatitis D, you need to have a hepatitis B virus. And it basically has the same signs and symptoms of hepatitis B. It's just more pure. It's only gotten when you have hepatitis B. So there's no way to get it when you're treating your patient with hepatitis D. Just realize that they also have hep B. We don't really know how hepatitis D came. There might be a change of the virus from hepatitis B. The big ones you gotta know: hepatitis A you get from eating shellfish. Hepatitis B is bloodborne sexual contact, as hepatitis C. Now, another sexual contact disease is HIV. Hepatitis can stay active in dry blood for 7 days. So be careful now when you're cleaning your equipment. Hepatitis can stay active in dry blood for 7 days. HIV stays active outside the body for about 10 seconds. It's a very unstable virus outside the body, but inside the body it does lethal things to your immune system. But when you have HIV, what's happening is you don't die from that virus. You die from the common cold. You die from cancers because your immune system has been destroyed by the virus. Signs and symptoms of acute HIV infection: you're going to have that immunoresponse. So you're going to have fever, malaise, swollen lymph glands. But serum conversion takes place in 3 months, and it starts to destroy your T cells. If your T cells get below 500, a white count, when it should be between 5 and 10,000, then you have AIDS, acquired immunodeficiency syndrome. And AIDS is a situation, it's a syndrome that has your body now open to any pathogen and makes for a hospitable host for an opportunistic infection to take hold of your body. And that's what you die from. Things like patients with AIDS will die from feline leukemia. They'll have terrible cancers. So look for things that are AIDS-related. PCP pneumonia, cytomegalovirus, the Kaposi sarcoma, KS, TB, and cryptococcal meningitis. When you're dealing with these patients, understand that a lot of like cytomegalovirus sounds really dangerous, but of all of those, cytomegalovirus is easily destroyed by a normal immune system. But without an immune system, it can take hold and it can be lethal. So patients with AIDS, you can get the transference of the HIV virus, but you're probably not going to get the diseases that they're carrying. But still, follow standard precautions. If you're exposed to an HIV or an AIDS patient's blood, always do a follow-up report. You can start with some they call them retroviral drugs that will prevent the HIV virus from locking onto the T cells, and those should be given within 48 hours, and they last for about 3 months sometimes, and they test to see if you had a serum conversion. So you're on the clock for 3 months, not where you want to be, so always practice safe standard precautions. Another type of virus out there is a norovirus. This is person to person, and it usually starts with ingestion of contaminated food. Patients are going to have GI disturbances because of the ingestion qualities: watery diarrhea, weakness, low-grade fever, and got to watch the communication. It is droplet transmission once it's in the body. I mentioned earlier about hepatitis A virus. This is a transmission of fecal-oral route, and a lot of times you can get hepatitis A. It can be triggered by poorly cooked shellfish. All right, so we talked about hepatitis D already. It's part of hepatitis B. Now, vector-borne and zoonotic diseases, these are diseases that are transferred from one species to another. Everything we talked about is human-to-human contact, but we have diseases that you can get from another species. West Nile, for instance, is a disease that can be transferred from mosquito to human. Lyme disease that's transmitted from a tick. Not a communicable disease, Lyme disease. It's only a zoologic disease. You see the Lyme disease, what happens in the localized area around the bite, you'll have this target, and what happens is it's going to start attacking the immune system and the neurologic system, the somatic nervous system. So this can be a major disease that can lead to heart failure and death. Rocky Mountain spotted fever doesn't have the long-term effects of Lyme, but it can be more lethal in the beginning. Rocky Mountain spotted fever, once again, is zoologic. It's transmitted from tick bites. Patients complain of fever, headache, abdominal pain, nausea. They have that rash. Looks a lot like meningitis. Your first-line treatment is a broad-spectrum antibiotic known as doxycycline. It is not a communicable disease. It's only transmitted from tick to human. Hantavirus is, you see this a lot on Long Island, places with a rodent population. It's found in urine, feces, saliva of these rodents. So if you're downstairs cleaning out your basement, you have a patient that finds themselves down there, and they suddenly, later on that day or the next day, they start developing signs of flu-like symptoms. They probably have hantavirus. They always make sure that when you're doing cleaning up rodents droppings, you're wearing a mask so you don't inhale the dust. That's where the virus is located. These patients will develop a sudden onset of fever with headache, abdominal pain, vomiting. The hantavirus is extremely dangerous, especially if it involves a respiratory tract in the system. as we go from phase 1, which is mild, to phase 2, now we start having issues with cardiac output, respiratory dysfunction, and we can have cell death and signs of hypoperfusion. So patients with the hantavirus, it's rarely transmitted from person to person. It's animal droppings to person. So use your standard precautions anyway, because it looks just like a communicable influenza. Cleanup of your ambulances just the same. The universal standard precaution should be the same, and treat that respiratory dysfunction. Rabies is another animal to human infectious disease transmission. Incubation about 2 to 8 weeks, and you're going to have that generalized part of your inflammatory response. Headache, weakness. You can also develop paresthesia. There's some neurologic issues behind it. And then as we get further along without treatment, the neurologic complaints become worsened, and it can lead to change in mental status, mood, behavior. Standard precautions with patient care. You know, these patients might present with a change in mental status, find out if they were bitten, and if they were they treated for rabies, they diagnosed with rabies. They're not going to give you rabies, but if you're ever bitten by an animal, which is a concern in emergency medicine because we're going into people's houses. If you're bitten by an animal, you have to make an assumption that it is rabid. Every dog bite needs to be evaluated at the hospital. Tetanus, this is brought on by spores that are enter the body through things like punctures or even contaminated street drugs. Anytime you have a puncture injury, you should have a tetanus shot. Tetanus shots you should have once every 10 years. Signs and symptoms of tetanus is mostly focusing on your musculoskeletal system. So you're going to have contractions, rigidity, and it's going to have a key sign of tetanus is the stomach feels very tight. There's no pain, you just feel like the stomach muscles are extremely tight. Now, the CDC has published reports showing that we as a society are overusing antibiotics. We don't let our immune system just run their natural course. And also, when we get an antibiotic, we only do the regimen until we start feeling better. And that doesn't mean that the bug is dead inside of us. It just means that our inflammatory response is lessened and we feel a little bit better, but we're still infected. So what happens is it's just a wounded organism that, and it's a living organism nonetheless, and just like all life, it wants to stay alive. So it will try and defend itself from this antibiotic next time. So that's how it gets drug resistant. Some of the big ones that we have are methicillin resistant Staph aureus. Now, Staphylococcus aureus used to be something that was easily managed with just regular broad spectrum gram-negative bacteria antibiotic, which is great. But then what happened was it got smart and it's now resistant, and now it becomes very opportunistic. So what happens with this is you can actually turn into a flesh-eating bacteria. Let's understand that this is a serious issue with nosocomial infections. Patients who are immunocompromised can develop this type of resistant staph infections known as MRSA. And it can lead to loss of major skin tissue, possible limbs. People with MRSA have an incubation period up to 45 days. And during this period, the communicable disease is, it varies with, once again, the virulence and the host can vary whether it's communicable or not. In addition to MRSA, we have VREs, vancomycin-resistant staph infections. Well, at risk of these are patients who have immunosuppression, severe health, underlying health issues like the elderly, recent hospitalization, people with indwelling catheters, they've had Foley's inserted, they've been on a vent for a long time. Because the two main ways that we can get MRSA internally is through the respiratory and the urinary tract. So VREs are treatable with very strong antibiotics. Understand that you can possibly become infected with this aggressive bacteria. You just have to use standard precautions and make sure hand washing is done, and most importantly, after your safety comes your other patient's safety. So clean your equipment, clean your stretcher, 2-minute wet time. The great thing about bleach, it kills everything. Why? Because it's a strong alkali, and alkalides killed by liquefaction necrosis, destroying the cell membrane. You're going to wipe out anything. It's broad, universal. So just cleaning it, wiping it down with 10% bleach and letting it air dry for 2 minutes destroys everything. So once again, that VRE, it's a nosocomial infection. You're going to find it in the urinary tract. And this is opportunistic to go up to the kidneys and into the bloodstream and become septicemia. Okay. In addition, these surgical wounds that are not treated effectively, that are not cleansed regularly, that can become infected with VRE. Well, we've wiped out a lot of different diseases in the United States over the years. I mean, there was a time when polio was a very serious virus that had neurologic complications, including paralysis. Franklin Delano Roosevelt, president, was paralyzed. He was in a wheelchair because of polio. Having inoculations, the polio vaccine invented by Dr. Jonas Salk stopped the polio outbreaks. So now you rarely hear anybody getting polio. So vaccination programs are vital for public health. Even though with vaccinations, children still get sick. And bronchiolitis is a very common pediatric disease. It's an infection of the lungs and airway. It looks like asthma, but you need to have a year of bronchiolitis symptoms to be diagnosed with asthma. So our management is oxygen and IV fluids, and if needed, assist ventilations with intubation. Croup is an inflammation of the larynx. It's viral in nature. Management, of course, is to keep the child calm, have the parents involved, give respiratory support, and if in severe cases, hydration with an IV. Measles is a highly communicable disease. If you have been exposed to a patient with the measles and you've never gotten the measles, you have to do an incident report, an exposure report. Early signs, we have fever, conjunctivitis, that inflammation of the conjunctiva with photophobia, followed with all different types of black, blotchy rashes and those Koplik spots you see pictured there. So management is really supportive care. Just, focus on airway management, breathing, circulation, limit your exposure, clean yourself, wash all your equipment. Highly contagious. You treat another child that hadn't had the measles after this patient's been dropped off and you haven't cleaned your equipment, you will transfer the measles to that child. Rubella, transmitted by direct contact with nasal secretions. Usually someone blowing their nose, you pick up the tissue with your hands, not good. Our pre-hospital care really is more of a supportive nature. Really the only way you can protect yourself is to be immune from it, get vaccinated against it. Mumps, same thing. We almost eradicated it. We have breakouts every once in a while. Mumps is a very serious respiratory disease. If left untreated, it can, or if the patient is immunocompromised, it can lead to respiratory arrest. So we we want to manage that, supportive care, wear gloves, do an exposure report, always notify the hospital you have a patient with mumps, just like the chicken pox. Chicken pox is, it's a virus, and it causes that horrible rash, itchy, fluid-filled vesicles. It's, the younger you are, the shorter time you have of the disease. When you get older, you've never had chickenpox before, it comes in and manifests itself as shingles. And that's a serious disease that can be life-threatening in some cases. It is highly contagious. They have vaccines now for chickenpox, so we want to avoid having it. Always make sure that you have the patient on an oxygen mask or an N95 mask, wear gloves, post-exposure. If you've never had a chickenpox before, you should do an incident report, do an exposure report, and get an immediate vaccination. Pertussis, known as whooping cough, this is something that comes on for about a month, lasts for about a couple months, and it's highly communicable in the first few days. Problems with pertussis, it can lead to lung infection and sudden respiratory arrest. Our management is going to be, of course, barrier devices. You know, if this is a respiratory disease, non-rebreather is always good. Make sure that when your supportive care is done, you drop the patient off and you clean all your equipment. SARS recently came into this country, maybe like 5-6 years ago. And this is something that is communicable person to person through close personal contact. We don't know the communicable period. It seems to have left, but it always has potential to come back. With SARS, we have a lot of general malaise, and it can be easily transferred. In New York City, we have a SARS protocol. Maybe other regions also have this, where if you have a patient who you are concerned have SARS, or if a class order has been sent out for SARS, then you limit intubations, and also for patients who are wheezing, you limit using a nebulizer that can actually increase transmission. That's something you got to really remember and focus on wherever region you work. In New York City, there's an actual protocols in the General Ops protocol for SARS. Bird flu, this is another animal to human transmission. Very contagious in domestic birds. Even though the risk of you getting it is low, it still can be transferred over. So patients with the bird flu, we want to treat them with body substance isolation precautions, you know, a surgical mask or a non-rebreather, and of course your annual flu shot will protect you. Now let's finish up talking about some immunologic emergencies. Focusing on allergic reactions, humoral immunoresponse. So 15,000 people die every year of acute allergic reactions, and this is a very serious issue and can easily be corrected with good education and prevalence of things like EpiPen autoinjectors. So immune response problems include that anaphylaxis, that respiratory component, as well as anaphylactoid, allergic reactions, hypersensitivity, collagen vascular diseases, and transplant-related disorders. And we're going to talk about each one. So what exactly is an allergen? It's something that will trigger this allergic response. An antibody is a protein that is part of the triggering that responds to destroy the allergen. And you can see IgA is part of your immunoglobulin antibody response, IgD and IgG and IgM, but IgE is the antibody that is predominant in allergic reactions. I always remember it's IgE because in allergic reactions I give Epi. We find the IgE antibody on mast cells, which are part of the immunoresponse. So allergic reaction is an abnormal immunoresponse. Localized, one area is cordoned off and we're dealing with the issue there. A systemic reaction all mast cells are secreting that histamine and the Ig antibody. People have a genetic predisposition to have that overreaction and overresponse. That's known as anaphylaxis. Not sure why this happens, it just does. It's the body's overresponse to really what is should be considered a mild, minor problem. Now, collagen vascular diseases like lupus, these are multi-system autoimmune disease. So the immune system is actually attacking different normal body systems. And these types of multiple system autoimmune diseases have very low survivability because you need your body systems to survive, and if the body is attacking them to kill them, you're eventually going to go into multi-system organ failure. Scleroderma is an autoimmune connective tissue disease, and it's seen visibly when it attacks the skin. Patients who have organ transplants are literally getting someone else's organ. Now, every organ has cells that have specific genetic identifying markers that the immune system is constantly checking to make sure that it's indigenous. Anything that doesn't have that genetic marker is considered to be a pathogen or an antigen or a foreign invader. So patients who receive transplants are receiving usually some that have very, very similar, if not almost identical genetic markers to fool the immune system into thinking that it's normal. But in order to maintain the illusion, a lot of patients, well, almost every patient, is giving an immunosuppression regimen of drugs. Now that could be a problem because if the immune system is suppressed, it makes for an opportunistic environment for pathogens to invade. So they're high risk for diseases. But they could have some really kicking immune systems that don't respond to that immunosuppression medications and begin to reject the organ. So our immune system, the normal immune system, we are comprised of two types. We have our cellular immunity, which is comprised of T cells, and we have our humoral, which are B cells. And the B cells produce antibodies. So working together, these two immune systems can combat a global scale of different types of antigens and pathogens. Now there's different ways that you can get an allergen into your body. You can have them through injection or absorption, you can inhale them, you can ingest them, we get that. Now, the primary response, we have those macrophages, T cells, they come in and they engulf and destroy these antigens. Antibodies actually make them inert. They wrap themselves around it, make them inert, and they send out distress signals, and the big fat macrophages come in and dissolve them. Now, the body begins to develop sensitivity, so every time it comes in contact with it, it's like a next response, higher, higher, higher response. Think about a normal response. I mean, you ask yourself, you know, in the post 9/11 era, are we ever going to have an attack like that again with two planes flying in the buildings? No, our response level is so heightened now. It was very similar in the body. Anytime it comes into contact with an antigen, the next time it sees it, it's going to increase its response. Increase and increase and increase. And that's how you develop a hypersensitivity over time. The ways that we actually have this response, we use basophils and mast cells. Now, basophils and mast cells produce chemical mediators like histamine, like Ig antibodies to fight these antigens. So you get an antigen admitted into your body. Let's say it's a bee sting. Okay, so the bee sting triggers this chemical response in the body. Mast and basophils secrete histamine and Ig antibodies that go and surround and make inert the antigen, and then the macrophages destroy it. But what ends up happening in a systemic response, every mast cell, every basophil secretes its histamine and Ig antibody. And what we end up with is a systemic reaction, the swelling of the respiratory center from that excessive histamine. Causes that wheezing and closure of the airway. The heart is going to have decreased output because we have too much fluid. All that histamine got dumped into the vasculature. Also, the histamine release is now causing skin irritation, and that's where we get the itchy urticaria skin. So we want to avoid that systemic response. That's an overreaction to something that can be handled very easily. The way that we make sure our immune system is working is, like I said earlier, we vaccinate. Vaccine sends that small dead virus into the body, and the body produces antibodies to destroy it, and those antibodies are stored so the next time it sees it, the antibodies are easily released and kills the virus faster. And we have our acquired immunity, that's what we are born with. Our natural immunity is when we end up acquiring it from the outside world, either through breastfeeding, the milk. Mom can transfer over her antibodies to the child. Also coming in contact, childhood vaccinations, getting sick, it's all part of living. You build that database. Herd immunity is when, like I said, we immunize a group, so they're all, and that's what we want to do in hospitals and police stations and firehouses, all right, is making sure that we immunize everybody. So when we're finding somebody with this type of issue, of course, do your scene size up and look for exposure venues, okay? What's the nature of the illness? Were they outside gardening and suddenly they got stung with by a bee? Maintain that same general universal approach. Evaluate their level of consciousness, their respiratory, work of effort of breathing, circulatory system, are they showing signs of shock? Allergic reactions can be local or systemic. We can treat local by giving an antihistamine like Benadryl to combat the itchiness, the urticaria, but we want to work on the serious ones that involve the respiratory center, and that's where epinephrine comes in. So we do that general impression. We look at level of consciousness. We want to see what their oxygen saturation levels are. Focus on the respiratory center, and just because it's nothing when you got there doesn't mean that it's not going to graduate into a respiratory impairment. So always do an ongoing assessment. As hypoventilation begins, we're going to start to hear diminished lung sounds and that silent chest, which is ominous. Circulation, we want to see that sign of inflammation, that erythema, the pruritus, the urticaria, all the stuff that you see with an allergic reaction. Our transport decision can include, are we going to secure the airway at the scene, or are we going to rapidly transport? This is where your role as a clinician is tested. This is where your skills are tested. And really what you got to focus on is the airway. People can deal with the itchy skin. They can even deal with the drop in blood pressure. You can combat that with fluid resuscitation. But they can't deal with a closed airway. And once that airway shuts down closed, you can't intubate through it. They may have to have a surgical airway, so you've got to make that decision fast. Think about this. Do they have a history of allergic reactions? Are they provided an EpiPen? Usually a patient who is prescribed an EpiPen has a history of anaphylaxis. The two go hand in hand. Right? So think about that. Did they take their EpiPen before you got there? If they did, we're going to think about the cardiovascular side effects of epinephrine. Okay? Look for signs of hypoperfusion. Narrowing pulse pressure. You know, the diastolic and the systolic are getting a little too close together. The mean arterial pressure is rising. What's going on with tachycardia? But really focus on the respiratory center. Get your baseline vital signs, and every 5 minutes take more. Over and over again. Since you're going to be giving us a stimulant, cardiovascular system and the patient is already secreting their own norepinephrine and epinephrine, make sure you have an EKG, and if you have time, 12 leads. End titles are vital, as well as pulse oximetry. Any reassessment should be done en route. This is a dynamic patient. They're getting worse and worse and worse. Even with your treatments, they can have closure of the airway, even with an EpiPen or 2 EpiPen administrations. So focus your assessment on the respiratory center. So those anaphylactic reactions, when the patient is hypersensitive, it'll be systemic in nature. The mast cells are stimulated to release histamine, which causes swelling, and the antigen IgE, which triggers the immunoresponse. Histamine is going to cause that vasodilation, increasing the permeability of the capillary beds. And then we have that leukotriene response, that white blood cell, the IgE antibody triggers it. And what ends up happening is we'll have coronary vasoconstriction, increased permeability, we'll start swelling, it'll go into the lungs, we may have fluid in the lungs, the edema can cause airway closure. Patients with no respiratory distress, but these signs, other signs and symptoms, they get Benadryl. Benadryl is an antihistamine, so it prevents the production of further histamine, but it does nothing for the existing histamine. Epinephrine will stop the respiratory involvement. Fluid will restore circulation. This is a form of relative hypovolemia. If there's no response with that, then we're thinking about giving a vasopressor. Think about an epi-drip, dopamine, whatever your protocols call for, whatever medical direction authorizes. But I'm going to give you a little clue. The doctor should be hearing sirens in the background when you're on the phone with them asking for dopamine or epi, for the simple fact that you should be en route to the hospital. If you're not en route to the hospital, you should have a good reason why you're still at the scene. So adults, remember, they get epinephrine 0.3 to 0.5 milligrams, and children 9 years of age and under, they get a weight-based epinephrine, or pediatric EpiPen. So, you know, we can think about, in addition to epinephrine and dopamine, we can use dobutamine, we can use Levophed as an alternative. But we're focusing on the airway compromise. So really, you know, instead of wasting the time to start an IV, you got to make sure you got that airway managed. So review those anaphylactic protocols that you have and focus on airway. Now we're talking about organ transplant disorders. The immune system can reject the organ even if it's under the immunosuppression anti-rejection drug regimen. What we're concerned about is respiratory cardiovascular pre-hospitally. Now in a heart transplant patient, sympathomedic drugs work, epinephrine and albuterol. All right, they work great, but atropine doesn't work. Why? Because it has an effect on the vagus nerve, and in a heart transplant, that vagus nerve has been severed. Liver transplant, watch for signs of infection, look for that, they'll have that yellower skin, signs of liver failure. Kidney transplant infections can lead to drop in blood pressure, they can lead to liver dysfunction, there's a variety of things, high fever response as a result. Lung transplants, some of the newer transplants are bilateral, but most lung transplants are unilateral in nature, only one lobe is replaced. Signs of rejection are going to be focused on respiratory. Pancreas transplant, this is something that's relatively new for different types of disease systems, but just realize that there's a high probability of those pancreatic enzymes leaking out into the abdominal compartment, in addition to rejection of the organ itself. So when you're doing these organ transplants patients, you're treating them, you gotta treat the acute signs. Even if you're doing a long distance transport, you gotta treat the acute signs of the rejection. There's nothing pre-hospitally you can do to fix the ultimate problem of rejection, but what you can do instead is manage the airway, make sure the respiratory center is clear, and treat for shock, circulatory compromise. Okay, and look for the signs of infection and a rejection, and you need to pass these findings along. If you're doing a critical care transport patient who's got a rejection, you got to make sure that their airway, breathing, circulation is all covered. These are patients you may need to sedate, do an RSI, and intubate them before you transfer them, because they're going to need to have surgical intervention at the receiving hospital. So you once again work along with your medical direction to decide the best course of treatment for this transport. And that's really what it comes down to. Maintain that universal algorithm, patient assessment, patient care approach for all patients, and you won't miss anything. Thank you.